Chapter 19, Documenting and Reporting. The patient record is a compilation of patients' health information. Each healthcare institute or facility has policies that specify the nurse's documentation responsibilities. The Joint Commission specifies that nursing care data related to patient assessments, nursing diagnoses, or patient needs, nursing interventions, and patient outcomes are permanently integrated into the record. The patient record is the only permanent legal document that details the nurse's interactions with the patient. It is the nurse's best defense if a patient or patient surrogate alleges nursing negligence. Unfortunately, there are crucial omissions in the nursing documentation along with meaningless, repetitious, or inaccurate entries. Although these entries might go undetected and have no effect on the patient, they might also seriously affect the care of the patient and undermine nursing's credibility as a professional discipline and cause legal problems for the nurses responsible. Okay, today we'll be talking about documentation and patient records, Chapter 19. The patient record is a compilation of patient health information. Each healthcare facility has policies that specify the nurse's documentation responsibility. Joint Commission specifies that nursing care data related to patient assessments, nursing diagnoses, patient needs, nursing intervention, and patient outcomes be permanently integrated into the patient record. The patient record is the only permanent legal document that details the nurse's interaction with the patient, and it's the nurse's best defense if a patient or patient surrogate alleges nursing negligence. Unfortunately, nurses are chronically and constantly leaving out things that should be documented in the patient's chart. So, along with meaningless repetition or inaccurate entries, these errors might go undetected and have no effect on the patient. They might also, though, be seriously affecting the care of the patient, undermining nursing's credibility as a professional discipline, and causing legal problems for nurses that are responsible for them. So, why do we document in a patient's record? The primary purpose is to help healthcare professionals from different disciplines communicate with each other, because we have a variety of different doctors, healthcare team members, x-ray techs coming on the floor, and they're doing things with the patient, and they're able to communicate these things that they're doing through the patient's chart. Communication also helps foster continuity of care. So by putting a note in the chart, someone else can come along, see what testing you've done, what treatments you've done, how the patient has responded to it. Because most of the disciplines are not in the room at the same time, the patient record is their primary means of communication. A nurse may check the record to see if the healthcare provider has spoken with the patient, or if the surrogate has issued a DNR order, a do not resuscitate order. Patient records also include diagnostic and therapeutic studies. Anyone reviewing the chart can find all the diagnostic studies ordered since admission. Illegible handwritten notes and typos have been the source of many errors. So when you're not sure about what has written in the electronic record or in the order, do not guess about it. Ask someone else, verify it. Each healthcare professional works with the patient, has access to the patient's baseline and ongoing data, and can see how the patient is responding to treatment from day to day. So data recorded on the patient in the records showing that the patient is becoming weaker and weaker and can now not tolerate ambulation justifies orders for physical therapy and other nurse-initiated ambulation issues that might have to be modified. So care plans and modifications in the care plans are often based on the data that's in the client record. Quality process and performance improvement. Documentation is the primary source of evidence to continuously measure performance outcomes against predetermined standards. Records can be reviewed to evaluate the quality of care the patient has received and the competence of the nurses providing that care. For example, during a nursing audit, a committee can evaluate interventions pertaining to the nursing assessment, nursing documentation, or safety measures. Nurses Researchers can also study patient records to learn how to best recognize or treat an identified health problem from the study or from looking at similar cases. The aim is to promote evidence-based practice in nursing and healthcare quality. Decision analysis information from the record often provides data so that strategic planners can identify strategies to use for treatment. The record can reveal both used and overused and underused services with the patient, especially those requiring prolonged stays, and financial information about which services generate revenue compared to those that cost the institution money. Credentialing, regulation, and legislation. Documentation helps reviewers monitor healthcare practitioners and the facility's compliance with certain standards of the profession and provision of care. And patient records are legal documents that might be used as evidence in court proceedings. 1 in 4 malpractice suits are decided based on the patient's record. So these records could implicate or absolve you as the nurse or another healthcare provider when they're charged with improper care. The record can also be used in accident or injury claims made by the patient. Reimbursement. Reimbursement records are used to demonstrate to payers that patients received the intensity and the quality of care for which the insurance company is being billed for. Then the records are organized and timed. So we should be documenting in a timely fashion, following facility policy, modifying if the patient's status changes and requires more frequent documenting. If you forget to document something, you have to remember to go back and make a late entry on that documentation. And then indicate in each entry the date and the time the entry is written, the time of pertinent observations and interventions. And many facilities will use a military clock to tell the time. So if you are using that military clock, make sure that when you get to 1 o'clock, you add 12 hours. So if you add 12 hours to the 1 o'clock, all right, so if it's between 1 p.m. and 11 p.m., you're going to add 12 hours. So 1 p.m. would be 1,300 hours. If it's 11 p.m., that would be 2,300 hours. And then 00 starts back at midnight. These elements of documentation also provide for confidentiality. Patients have a moral and legal right to expect that information in their record will be kept private. Students need to be familiar with facility policies and the guidelines regarding that HIPAA policy or that privacy. The Health Insurance Portability and Accountability Act protects the privacy of individuals. Identifiable health information. The HIPAA Security Act, which sets national standards for security of electronic protected health device, requires covered entities and businesses associated to provide notification if there is a breach of that unsecured protected health information. The confidentiality provisions of the patient safety rule, which protect identifiable information being used to analyze patient safety events and improve patient safety. The final HIPAA regulations were released in August of 2002. So most facilities now require workers to undergo HIPAA training and review and sign a confidentiality agreement when they're hired and during each performance review. A student in a healthcare setting should discuss privacy guidelines with their instructor and nurse mentor. So there's your military clock. Remember what I said, if it is 11, if it's 1 p.m. to 11 p.m., you're just going to add 12 hours, okay? When you add 12 hours, then that brings you that number. So at 1 p.m., if we added 12 hours, that would give us 1,300 in military time. What is confidential? So patients have a moral and legal right to expect information contained in their pertinent health record will be kept private. Students should be familiar with the facility policy and pertinent legislation. All information about patients written on paper spoken aloud, saved on a computer, such as name, address, phone, fax, social security number, why the person is sick, the treatments they're receiving, or information about past health conditions. Anything that could connect that patient or connect that information to the patient would be considered a HIPAA violation. Violations include improperly accessing records that you shouldn't be looking at, uh, improperly accessing, reviewing, or releasing patient information on anyone. It's someone that you're in a personal relationship with, someone who's a public personality, someone that's your neighbor, or someone that works with you. You cannot access or use anyone's information unless you're using it in the nursing context and you are assigned that patient. Breaches in patient confidentiality include displaying information on a public screen where others can see it, sending confidential emails through a public network where others can hack it, sharing printers in units with different functioning. So if someone else has access to that printer or that fax machine, and then sending confidential messages that could be overheard on a pager. All patients have rights. You should be aware of those rights. According to HIPAA, they have a right to see and copy their health record, update the health record, get a list of disclosures, request a restriction on certain uses or disclosures, and choose how to receive that healthcare information. For verbal orders should only be received in an emergency. Record the orders in the patient's medical record. Read back the order to verify the accuracy and write that on the order that it was read back for verification purposes. Date and note the time the orders were issued. Record the verbal order, the name of the physician issuing the order, followed by your name and initials. When you receive a verbal order, record it in the patient's chart. Read the orders back to the practitioner to verify accuracy, and again, document that on the order. Date and note the time the orders were issued. Record telephone orders, full name and title of physician or nurse practitioner, and sign the orders with name and title. Make sure that you know what your company's policy is. Like at my facility, you cannot take heparin or insulin orders without a second nurse on the phone to verify the order. If a health institution wants to release a patient's health information for reasons other than treatment, payment, or routine healthcare operations, the patient must sign an authorization notification. Take note, HIPAA legislation includes punishment for anyone caught violating patient privacy, and it could be as much as $250,000 or jail as long as 10 years. Another strategy that the Joint Commission is using to achieve national patient safety goals is a list of do not use abbreviations. And these abbreviations and symbols should not be used anywhere by anyone. So every place that you work will definitely have a list of information that you should or should not use as far as abbreviations. So make sure that you're aware of that and then that you're not using those abbreviations, because a lot of them are abbreviations that could lead to errors, and that's why they have discredited them. Okay, purposes of recording data. So the aim is to provide complete, accurate, concise, current, factual, organized data that's communicated in a timely and confidential manner to facilitate care and coordination and serve as a legal document. By recording data, it facilitates quality and helps us to provide evidence-based care. It serves as a financial and a legal record. It can help for clinical research, and it helps support our decisions made. When we analyze and we make decisions, it helps support those decisions. Many people today prepare online personal health records, and they manage their health care on the computer. The records may contain medical history, diagnoses, symptoms, medications. Sometimes patients will scan in doctor's notes, test results, etc. The chief reason for a personal healthcare record is to provide easy access to assist in self-care and communication with the providers. So there are two types of personal health records: a standalone health record, in which the patient fills the information from their own records. The information is stored on the patient's computer or the internet. In some cases, these standalone health records can also accept data from external sources like providers or laboratories. Patients could add diet or exercise information, and they can decide on whether to share the information with providers, family members, or anyone else. And then we have tethered or connected personal health records, and these are linked to a specific healthcare organization's electronic health record system or to a health plan information system. With the tethered personal health record, patients can access their record through a secure portal and see the trend of their lab results over the last year, their immunization history, or due dates for screenings. Benefits of the health information exchange include allowing doctors, nurses, and pharmacists, as well as other healthcare providers and patients, to appropriately access and securely share a patient's vital information. It provides a basic level of interoperability among electronic health records maintained by individuals, physicians, and organizations. It can improve the speed, the quality, the safety, and the cost of patient care. Appropriate time sharing of vital patient information can better inform decision making at the point of care and allow providers to avoid readmission and medication errors, as well as improve diagnoses and decrease duplicate testing. Benefits also include providing a vehicle for improving quality and safety, provides a basic level of interoperability among electronic health records maintained by individual physicians or organizations. It stimulates consumer health, consumer education, and patient involvement in their own health care. It helps public officials meet commitments to the community. It creates a potential loop for feedback between the health-related research and the actual practice, and it provides the backbone of technical infrastructure for leverage by national and state levels. Methods of documentation include source-oriented records, problem-oriented medical records, SOAP notes, pie charting, which is problem intervention evaluation, focus charting like data, action, and response, charting by exception, and case management models. With source-oriented records, sections of the record are designated for nurses, healthcare providers, lab, x-ray personnel, and so on. Even though the notations are entered chronologically, and each discipline can find the chart data easily, most of the entries are noted at the front of the record. The most recent ones will be at the front of the record. So that helps the disciplines to easily find and locate the information that they've charted there. Problem-oriented medical records are organized according to the person's specific health problem, and that includes a database, problem list, plan of care, and progress notes. Like the SOAP note, okay, it records subjective, objective assessment, the care planner's judgment about the situation, and it's used to organize entries. Variants of the SOAP include SOAP-E, SOAP-I, SOAP-er. So intervention, evaluation, and response. The pie charting, which is problem, intervention, and evaluation, and this does not develop a separate care plan. The care plan is incorporated into the progress notes, in which problems are identified by number and worked up using the problem, intervention, evaluation format. Then we have focus charting, which is data, action, response, a documentation system that replaces the problem system with the focus column that incorporates many aspects of a patient and patient care. The focus may be patient strength or a problem or a need. The narrative portion of focus charting uses data, action, and response format. Charting by exception, this is a shorthand method for documenting, and it's based on well-defined standards of practice. Only exceptions to the standards are documented in the narrative notes. In other words, we document the abnormal findings for the patient. And then case management model. This managed care's emphasis on quality, cost-effective, delivered within a limited time frame. It has led to the development of interdisciplinary documentation tools that help identify outcomes that select groups of patients that are expected to achieve on each day of care. So case management promotes collaboration, communication, and teamwork among the caregivers. It makes efficient use of the time and increases quality by focusing care on carefully developed outcomes. One limitation of this model is that it works best for typical patients with few individualized needs. And then critical pathway. This is a case management plan that is a detailed, standardized plan of care, and it will help develop outcomes, interventions to be performed, and the sequence and timing of those interventions. And it's developed for a patient population with a designated diagnosis or procedure. So this is a sample focus care note. So as you can see, we have the data and the action, or the data, the action, and the response. Formats for nursing documentation. When the nursing process is fully implemented, nursing documentation in the patient's permanent record includes the following formats: the initial nursing assessment, the care plan or the patient care summary, the critical collaborative pathways, progress notes, flow sheets and graphic records, medication records, acuity records, discharge and transfer summary, long-term care, and home care documentation. Documentation in long-term care settings is specified by the Resident Assessment Instrument tool, which helps staff gather definitive information on a resident's strengths and helps meet the needs and addresses these in individual care plan. The Resident Assessment Instrument includes 4 basic components. The first one is a minimum data set. This is a core of screening, clinical, and functional status elements that form the foundation of the comprehensive assessment of all residents in a long-term care facility, and it helps certify them to participate in Medicare or Medicaid. Items in the minimum set data standardized communication about residents' problems and conditions. Triggers. These are specific resident responses for one or a combination of minimum set data elements that identify residents who either are at risk for developing a specific functional problem or require further evaluation using the resident assessment protocols. Resident assessment protocols are a structured, problem-oriented framework for organizing minimum data set information and for examining additional clinically relevant information about the resident. The resident assessment protocol helps identify social, medical, nursing, and psychological problems and form the basis for individualized care planning. Utilization guidelines are specified in state operation manuals that direct when and how to use the resident assessment instrument. Statutory law, federal regulations, and Healthcare Financing Administration specify how this resident assessment instrument is used, or implemented. It must be completed for residents of Medicare skilled nursing facilities or Medicaid nursing facilities, hospice residents, and short-term stay or respite residents who reside in a facility for longer than 14 days. The benefits of this resident assessment instrument include that residents respond to individualized care, staff communication becomes more effective, resident and family involvement will begin to increase, and documentation becomes much clearer. Medicare requirements for home health care are that the patient be homebound and still needs or still requires skilled nursing care. Rehab potential is good, or the patient is dying. The patient's status is not stabilized, or the patient is making progress in an expected outcome of care. The OASIS Outcome and Assessment Information Set. The Outcome Assessment Information Set, OASIS, is a group of data elements that represent core items of a comprehensive assessment for an adult home care patient. Form the basis for measuring patient outcomes for the purpose of outcome-based quality improvement. The OASIS is a key component of Medicare's partnership with the home care industry to foster and monitor improved home care outcomes. Overall, the OASIS items are useful for outcome monitoring, clinical assessment, care planning, and other internal facility-level applications. OASIS data items encompass socio-demographic, environmental, support system, health status, and functional status attributes of non-maternity adult patients. So the handoff communication, or the ISBARR, we talked about this earlier in another chapter. I stands for identity or introduction, so the student introduces themselves and the patient. Situation is the current situation of the patient or the current status. Okay, we don't want to know what happened the last 20 years, what's going on right now. The same thing with background. The background is what's happening or what led to this patient issue at the moment. What is the background in relation to the situation at hand? And again, we don't want what happened 40 years ago. All right, this is why you want to have the patient's chart there and ready, so when the doc asks you questions or when you're trying to give this report, you'll be able to do it. And then assessment. Okay, how does the patient look? And then what is your recommendation or the recommendation of the physician? And then read back of the orders and the nurse's response. So you want to make sure that happens, that everything was understood, that the doc understood everything about and wrote the right orders. So this handoff communication occurs between nurses and other departments. It was an effort by the Joint Commission to eliminate breakdowns in communication and adverse events. Remember, it used to be ISBARR, but the Quality and Safety Education for Nurses wanted to add the I for the identity and introduction and the R for the readback of orders in response to making sure that nursing students also could use this tool safely. Okay, so they suggested that using the standardized framework like the ISBARR can help reduce perceived anxiety and increase confidence related to handoff report in nursing students. And then remember, the Joint Commissioner Center for Transforming Healthcare added the TST, the Targeted Solutions Tool, which examines the handoff communication problems and identifies causes for failures and barriers to improvement. This also provides validated solutions to improve handoff communication targeted to specific causes of inadequate handoff at an individual organization. So, not giving a good communication report to someone that you're dealing with, either another worker or a physician, someone that you're trying to give a report to. Before you call the health provider, make sure you assess the patient. Make sure you review the record for appropriate healthcare provider to call. Know the admitting diagnosis. Read the most important physician and nursing notes. Have the record at hand and be ready to report allergies, medications, IV fluids, labs, and test results. Every ISBARR is important and different. Focus on the problem, be concise. Not everything in the following outline needs to be reported, just what is needed for the situation. So change of shift, handoff reports. You're going to give basic identifying information about the patient, the name, the room number, the bed designation, the diagnosis, and attending and consulting physicians. And if you're working on a hospital floor, it's probably going to be more than one patient. Current appraisal of each patient's health status, current orders, any newly changed orders especially, abnormal occurrences throughout the shift, any unfulfilled orders that need to be continued into the next shift, patient family questions, concerns, and needs, and any necessary reports on transfers or discharges. Identify yourself and the patient when you call. State your relationship to the patient. Report concisely and accurately the change in the patient's condition that you're concerned with and what's already been done in response. Report the patient's current vital signs, clinical manifestations. Have the patient's record at hand to make knowledgeable responses to any physician inquiries. Concisely record the time, the date of the call, what was communicated, and the physician's response, regardless of what it was. Because sometimes physicians will say stuff to you like you're bugging them, or they can get kind of angry because you called them. So, you want to be careful about what you document, but at the same time, you want to document what that physician's response is. When you're conferring about care, that means you're consulting with someone or exchanging ideas or information, advice, instructions. The nurse can consult with other nurses. She might consult with a specialist, a physician, a psychologist about a behavior problem. All right, you might consult with speech about a concern of dysphagia. A community health nurse and healthcare provider can confer about a patient's activity regimen. So, these are different ways. So, consultations and referrals. When nurses detect problems they cannot resolve because of the problems are outside the scope or outside of the nurse's expertise, then they consult with or make referrals to other disciplines or professionals. This is called a referral. Nurses and other healthcare professionals frequently confer in groups to plan and coordinate care. Such conferences are used for instructing students and practitioners. A nursing care conference is a meeting of nurses to discuss some aspect of the patient's care. Nursing care rounds are procedures in which a group of nurses visit select patients individually at the patient's bedside. The primary purpose of nursing care rounds is to gather information to help plan nursing care, to evaluate the nursing care patients have already received, and to provide the patient with an opportunity to discuss their care with those administering it. As each patient is visited, the nurse's sign provides a short summary of the patient's nursing diagnosis and goals and the care being given. Purposeful rounding. There are 8 behaviors of purposeful rounding. This is a proactive, systematic, nurse-driven, evidence-based intervention that helps the nurse anticipate and address patient needs. So as you round, you would use opening words such as, "See, I care." That's interpreted by your presence. You would accomplish your scheduled tasks while you're in the room. Address the 4 P's, positioning, personal needs, pain, and fall prevention. Address additional personal needs and questions. Conduct an environmental assessment. Ask the patient if there's anything else you can help them with and let them know that you have time to assist. Tell the patient when you will be back and then document the round.